Thank you very much. I will share with you a video presentation of a single-stage breast reconstruction with an ADM and an implant. I would like to reinforce to those of you who have not been here yesterday that this is not an operation that you can do by yourself. This is a team effort that has to do with the general surgeon who does a mastectomy, the plastic surgeon who does a reconstruction, the radiation oncologist, and the patient. Any one of those individuals can destroy the efforts of doing the good work, both oncologically and aesthetically. And unless you work together as a team, this can never happen. ADMs and TRMs. ADM is acellular dermal matrix made of human and mammalian origin, of cows, of pigs. And there are other xenografts and synthetic meshes made of silk, of suture material, Vicryl, PDS, etc. So together there are almost 50 different types of ADM, which are very different from each other, yet they all seem to work in a similar way. The meshes that we have had experience with in the last 6 years are Alloderm, Surgimend, Tiger mesh, which is a PDS absorbable mesh, silk mesh, and a couple of cases of porcine with permacal. How does it work? The matrix offloads the pressure from the inferior pole of the skin envelope. Thereby, it reduces fibroblast proliferation and stimulation. And therefore, there is a regenerative milieu that has less inflammation, less proliferation, and less capsule contracture. What is the evidence that this works? In the world, and especially in the United States, level of evidence has become very important in everything we speak about and write about. All the evidence about breast reconstruction with implants and ADMs are level 3 evidence, which means case control studies with a systematic review. There are many publications in the literature. Some have negative outlooks. You see the names of the people that has written them, you know that they will have a negative outlook if you know the institutions and the literature. These groups have compared patients that had partial muscle coverage and an ADM or a tissue reinforcement matrix and total muscle coverage, and found a much higher complication rate with the ADM group. So they say that it has more infection, seroma, skin necrosis, and reconstructive failure when you compare the ADM to the total muscle coverage. The other group is a positive outcome group published in the same journal by important people that showed that partial muscle coverage with ADM results in a complication rate that is similar to total muscle coverage. Why is this huge range of complications between different institutions and different surgeons? You can see that infection rate, seroma rate, skin necrosis rate, explantation rate, for example, varies from 5% to 20%. Why is that? This is because nothing is standardized. Patient selection is not standardized. The algorithm of choosing an incision, an implant, a one-stage or two-stage, the learning curve of the surgeon, when you start you have more complication, definitely. The mastectomy technique is different, the reconstructive technique is different. The intraoperative and post-operative regimen is different from one surgeon and one hospital to another. Hence, the big variability in complications. When you do a meta-analysis of all these literatures, what you find out that the only complication that is really higher in patients with TRM or ADM is seroma. So I will show you now, I will share with you what has worked for me, the way I do that. I start by the marking of the patient. This is a patient with a relatively large breast. We mark the confines of the breast in the inframammary fold. The inframammary fold often is different when the breast is falling from one side to the other, and you need to know that, because when the patient lies down, it will not be there. Also, I mark the heights and position of the nipples with the patient's arm up on her head in 45 degrees. And you can see the difference there. This is significant. I now measure the volume of the breast using the salad balls plastic mount, and this is 550 to 575. Obviously, if you put tumescent solution in the breast, it will be a little bit more. I now tailor tuck the breast with a horizontal ellipse going around the nipple areola, and a vertical ellipse going vertically down, overlapping the same ellipse in the center. With a red marker, I delineate my incision. The skin that is beyond my incision can be deepithelialized, trimmed, or you can do whatever you want with that skin. I mark the difference, I look at the patient, and I take her for surgery. In surgery, I tumesce the breast. I measure the perfusion of the skin envelope before, during, and after the mastectomy. Here we are two surgeons lifting the skin off the breast tissue. It's easy to do that, and you make a small incision so you don't need any retractors pulling up on your skin and crushing your skin envelope. It is very safe because we use the same thing. We use the same thing in the face when we lift the skin off the facial nerve. So it's certainly something we can do off the breast. I want you to look at this picture. The surgeon on your left, she's holding the breast down, and her assistant putting clamps on the skin, pulling the skin up. The surgeon on the right, the assistant is pulling the breast down, and the surgeon is holding the skin flap of the breast up. Now, if we bring the laser Doppler camera inside and measure the perfusion and the blood supply to the skin envelope on the left side and on the right side, we see that on the right side it is 96% of normal perfusion, whereas on the right side, on the left side, it is 50% of normal perfusion, and that's important. So now we have fallen into the cavity because we have raised the skin envelope of the breast, and all there is left to do is to peel the breast of the pectoralis major muscle. We wash our skin flaps and the cavity from within side with a triple antibiotic solution. We mark the inframammary fold on the origin of the pectoralis muscle, and this is looking from the side on the right breast. We mark where we want the lateral border of the implant to be, and we mark the lateral border of the pectoralis major muscle. Before we do anything, we put a sizer inside and we measure the perfusion as well. Because if the perfusion is not good, we'll use a tissue expander. We go back in, we raise the lateral edge of the pectoralis major muscle without yet detaching the origin of the pectoralis major, and we go all the way medially. Once we have done that, we detach it and we take our mesh. In that case, it would be this was a surgiment, and this is a seriscaffold. Seriscaffold is a netty, porous, open product made out of silk. And I'll try to show you how it's being sutured in, both with either product. It's sutured to the cut end of the pectoralis major muscle, and then to the IMF. Or you measure how much you need with the skin closed. Then you trim it. You put 3 stitches to the inframammary fold. You put the implant in. You pull the muscle down and the ADM up, or the tissue reinforcement matrix up. Then you put your first suture onto the cut edge of the pectoralis major muscle. And now you see there is an indentation here, so you release one muscle, one stitch, because you want the lower curvature of the implant to be against the skin, so that you minimize the incidence of seroma. You then suture the product with as little as possible sutures to fit onto the muscle, the inframammary fold, and the lateral confines of the implant. When you're done, this is looking at the right wrist from below. The implant is sitting on the rib cage, and it is fixed there with the seriscaffold or your ADM. It's not falling off the ribs. It is very stable right at the lateral confines of the implant, the medial cleavage of the breast, and the inframammary fold. Then, before closing, you trim the edges of the skin, because usually the edges are traumatized. You could also deepithelialize it if you want, in order to have a very good, well-vascularized closure, because this patient might need to have radiation or chemotherapy, and you want her incision to close perfectly. When you've done that, you trim the subscarpa fat. Subscarpa fat is parasitical fat that doesn't have any good blood supply. So here's the patient that we just operated on together. Here she is before, and here she is 3 weeks post-operatively. See if that works. It doesn't. So here she is before, here she is 3 weeks post-operatively, here she's trying to animate her breast, but nothing really moves. This is 3 weeks post-operatively. You know that this patient is doing well. She can have radiotherapy, chemotherapy if necessary, and she will not need another operation unless she decides to have a nipple reconstruction. So I'll stop here, and if you have any question, I will be happy to entertain them.